I'm Ashvini. I'm an F1 doctor in North West London. Ellie is also an F1 doctor who's down in Exeter. She's just running a bit late from work, but she should be joining us in a little bit. So today's finals crash course is on cardiology finals. So I'm doing part 1 and then Ellie will be doing part 2. I've also put my email here in case anyone wants to email me just with any questions about finals or F1 applications, anything like that. Okay, so first topic we're going to go through is hypertension. So hypertension is the increase in your blood pressure, which can't be controlled by your homeostatic response. So usually risk factors is things like age, diet, lack of exercise. You can also get secondary hypertension due to endocrine causes such as pheochromocytoma, Cushing's disease, renal causes such as AKI, CKD, drugs such as steroids or oral contraceptives, NSAIDs, SSRIs as well. So hypertension is classified into different groups. So this is your normal blood pressure. So it's usually around 120, less than that, systolic. And the systolic blood pressure is the one that you look at mainly. If it's slightly elevated, it'll go to about 130 max. And then stage 1 hypertension is about 130 to 139. And at this stage, you'll usually think about things like lifestyle modifications. Stage 2 is 140 or higher, and this is where you'd start considering any kind of medications, and I'll be going through that in a little bit. And then you've got your hypertensive crisis, where your blood pressure is higher than 180, and this is quite serious and needs immediate intervention, and occasionally you might end up having to go to A&E. So there's a few complications that you need to also remember with persistent high blood pressure. So hypertensive retinopathy is one of them. So it's because of the increase in pressure in the eyes can cause damage to the retina. You're more likely to get things like stroke or confusion from other kind of encephalopathies. Your blood pressure can also lead to things like elevated blood sugars, hypertensive neuropathy as well, which can lead to CKD, and it can put a lot of pressure on your heart, which can result in things like an MI or cardiomyopathy and eventually lead to heart failure as well. So I've got an SPA here. So you have a 45-year-old Afro-Caribbean woman who's given a new diagnosis of essential hypertension. Which of these would be the first-line option to treat her condition? So I'll give you a couple seconds if you can put the answer in the chat. I'll time you for about 20 seconds. Okay, 5 seconds left. Okay. So yeah, so F is the correct answer. So good thing you kind of pulled yourself out of that trap of giving amlodipine straight away. So you're correct in saying amlodipine would be the first line drug that you would consider if you were going to start them on a drug, but first line management is always lifestyle modification. So I've just kind of put this here. This is from the NICE guidelines, and I thought this was quite useful just to think about how you'd manage their blood pressure. So first you want to make sure that you've got the correct reading. So you can get something like white coat syndrome. So the blood pressure reading at the GP surgery, for example, will be a bit higher than what it would normally be. So you get them to do ambulatory or home blood pressure monitoring, and you take an average throughout a week. And if that's within normal range, then they probably don't have essential hypertension. And it was just probably a one-off reading that you got. If they do have a high blood pressure, then you'd want to consider starting them off, start working their way up the management ladder. So, in terms of drug therapy, first line is usually ACE inhibitor, and if they're not tolerating ACE inhibitors because they've developed a cough, which is a very common side effect of this, you can start them on an angiotensin receptor blocker. So this is usually for anyone who's aged under 55. Now, if they're over 55 or if they're Afro-Caribbean, then you'd start them on a calcium channel blocker instead, so something like amlodipine. And the reason why they specifically say Afro-Caribbeans is because they don't respond very well to ACE inhibitors or ARBs as well in the first instance, like they will for calcium channel blockers. Then step 2, then you'll start thinking about adding in one of the other drugs. So if you look at this side, you'll start adding on a calcium channel blocker or a thiazide diuretic instead. And with this side, you think about ACE inhibitors or an ARB or a thiazide. Then step 3 is combining all of these, and step 4, if you really need to step it up, then you think about adding other anti-hypertensives, so things like spironolactone, for example, an alpha blocker or a beta blocker as well. But at this stage, you'd want to actually get specialist advice on how to manage the blood pressure. Okay, so in the NICE guidelines as well, they've also got these target ranges. So with elderly patients, you'd actually aim for a little bit higher. So if their blood pressure is running a bit higher than what you'd want, that's actually okay, because they're more likely to end up being hypotensive, which can lead to falls. So it's better for them to have slightly higher blood pressures. They can also end up with postural hypotension, which is another reason why you would want to keep their blood pressure a bit higher. And you'll see in elderly care, they'll just stop their blood pressure tablets very commonly, because it's a kind of risk-benefit weighing up that we do to kind of figure out if they'd actually benefit from having these antihypertensives or if they're actually better off not having it. So with hypertensive crises, this is usually like accelerated hypertension, where the blood pressure is over 180, and they present with neurological symptoms as well. So things like cardiac symptoms, they might have increased urine output or no urine output, changes in their vision as well. And if you do fundoscopy, you can see things like retinal hemorrhages or papilledema. And standard management for this is labetalol, given the nicotine or glycerol trinitrate. And you might need to step this up if they've got a pheochromocytosis crisis, where you give them phentolamine instead. So we've got a next SBA here. If you do have any questions as well, please feel free to stop me. I'm happy to answer them. So the SBA here is, we've got a 75-year-old man who complains of palpitations, shortness of breath, chest pain, and nausea and vomiting. He has a background of type 2 diabetes, ischemic heart disease, and hypertension. Blood results are unremarkable, except for their elevated potassium of 6.3. Which of his medications may be causing hyperkalemia? So we've got a list of his medications here. So in the chat, just put down which one you think it might be. And I'll time it for 20 seconds again. Okay. Cool. So we have C, which is the correct answer. Well done. So spironolactone is a potassium-sparing diuretic. So that means you're more likely to retain that potassium, leading to hyperkalemia. And I've also put this table together, which I thought might be useful, and you'll have access to once you fill in the feedback, and obviously with the recording as well. But I thought this was quite useful because these questions do come up in finals, and also quite useful for your PSA as well. So ACE inhibitors, like I mentioned before, a dry cough is usually your kind of common side effect that you get there. Hyperkalemia with ACE inhibitors is not very common, but it can be an adverse effect. Same thing with angiotensin receptor blockers as well. It can be an adverse effect, but it's very rare, where it's more common with potassium-sparing diuretics. Okay. So the other things that you'd want to just kind of remember is things like beta blockers lowers your heart rate. So you might get patients who might come in because of a fall, and this is one of those drugs that you'd want to kind of consider altering, maybe reducing the dose or stopping, because this could be a culprit for falls. Again, things like thiazides as well. It leads to electrolyte abnormalities as well. So that's another thing that can be considered stopping as well. Okay. Next, SBA. We've got a 55-year-old man who's rushed into ED with a 2-hour history of crushing epigastric pain, nausea, and shortness of breath. He's very clammy. His pain has not stopped with 2 doses of his GTN spray. He has some bloods taken and his troponin comes back as 45. What's likely to be going on? So if you put your answer in the chat, I'll time you for another 20 seconds. Oh, 5 more seconds. Okay, so got answer, got D, which is correct, so well done. So your typical presentation for an MI is usually the sort of crushing chest pain, which can radiate to the shoulders, arms, abdomen, neck or jaw. In some patients, especially like diabetes patients, they can get atypical presentation, so their pain might be somewhere else, like so a bit more like abdominal pain more than epigastric or chest pain. Nausea and vomiting is another common symptom, shortness of breath, feeling lightheaded. Sometimes they can actually be lose consciousness as well, and being sweaty and clammy is another typical symptom. So just going to go through acute coronary syndromes now. So risk factors for this is high cholesterol, hypertension, smoking, diabetes, obesity, age, having a family history as well is a strong indication that you're prone to it. It's more common in males than females. In females, you're more likely to get it at a later age, mostly like postmenopausal or after like 65, whereas in males, they'll get it at a younger age. And this is because the estrogen kind of protects our cardiovascular system. And other risk factors also that you want to consider is like vasculitis, drug use as well. So things like cocaine can lead to coronary vasospasms and aortic dissections. So with their clinical presentation, it could be various things. So you put them on your ACS management, which is giving them dual platelet therapy, so aspirin, and in depending on your trust, it's ticagrelor or clopidogrel. Both, and so you put them on both of them. Give them oxygen if they need it, morphine for the pain, and give them a nitrate as well. So once you start them on this, then you'll do an ECG, you'll look for an ST elevation, and this will help kind of start classifying what's going on. So if they've got an ST elevation, then it's a STEMI and you ship them off for a PCI. Obviously do a TROP as well. If they don't have an ST elevation, it's an ST depression or a T wave inversion, then you'd have to compare that to the TROP. If the troponin is elevated, then it's an NSTEMI. If it's not, then it's very likely that it's just unstable angina. And if the ECG comes back normal, then you'd want to start considering a different diagnosis. Now, with the troponin, you would look for an elevated troponin of 40 nanograms per litre. If it's between 14 and 40, then it's unlikely, but you wouldn't want to rule out your ACS. So that's why it's really important to take two troponin readings a couple hours apart, because it takes a couple hours for the troponin to rise, and you'll look for that rise in the troponin. And in the meantime, you'd be monitoring the patient as well. Okay. And other things just to note as well, things like CKD, sepsis, and any kind of cardiac infections and PE sometimes also lead to a TROP rise, but usually won't be more than 40. Sometimes can be, especially if it's been ages since you've had CKD. So those are kind of things that you'd want to also consider if the ECG is normal, but you have a TROP rise. We've got an ECG here. So this is a 12-lead ECG taken in a patient on a surgical ward following complaints of a chest pain, episodes of vomiting, and seems quite feverish. So what's the likely diagnosis? So if you put the answer in the chat, I'll time you again for 20 seconds. Five seconds left. Okay, so yeah, so C is the correct answer. So it's an anterior STEMI. So you can see these are the anterior leads, so V1, 2, 3, and 4. So these are the anterior leads, and you can see there's an ST elevation in all these leads, and this is quite a classic STEMI. You can also argue it's an anterior lateral because you've got some of the lateral leads. So V5, V6, not so much in V1 and AVL, but there's a slight rise there, so you could argue it's an anterior lateral there as well. But as an SBA, the best answer here is an anterior STEMI. So just to kind of quickly go over ECG changes. So this is your ST segment in a normal ECG. It's just like a flat line, and it progresses to a T wave. Here you can see at the end of the QRS complex, the ST segment is elevated above the isoelectric line. In an N-STEMI, you get this depression where it's below the line, or you get a T wave inversion. And N-STEMIs can also progress to a STEMI, so that's also why you would keep the patient in and monitor them. So just to quickly go over the different territories. So you've got your inferior leads here, which is 2, 3, and ABF, and this is supplied by the RCA, so the right coronary artery. You've got your lateral leads 1, ABL, V5, and V6, which is supplied by the circumflex arteries. And then you've got your septal and anterior leads, V1 to 4, which is supplied by the left ascending. So different types of MI. So there's 5 different types of MI that you can get, and it depends on what's kind of causing it and when it happens as well. So your type 1 and 2 are quite similar. So type 1 is usually quite spontaneous, and it's due to maybe a rupture of a plaque in the coronary arteries, or kind of a dissection or something like that. Whereas a type 2 is usually due to an increase in oxygen demand from occlusion of the artery instead. Type 3 is kind of unexpected death due to a possible MI, and that happens really quickly. And type 4 usually happens during a PCI, where whilst they're doing the procedure, they end up causing the MI because they're oxygen deprived. And then type 5 is usually associated when they're doing surgery, so it could be any sort of cardiac surgery. So I've gone over the immediate management already and just put it there for reference. In terms of the next steps, it's usually PCI or fibrinolysis. So indication for PCI is usually within 90 minutes of arrival for a STEMI, or if the symptoms are, have occurred within 12 hours. You'd want to anticoagulate them as soon as possible. So on top of the dual antiplatelet that you just gave them, you'd want to put them on a low molecular weight heparin or fondaparinum. End-STEMI, you'd consider fibrinolysis, and then you would consider the PCI based on how high a risk they are. So if they're very high risk, then within 2 hours, you would want to get the PCI done. If they're just high risk, then within 24 hours, and if it's kind of intermediate, then 72 hours. And the whole time they'll still be in hospital in the cardiology ward, and you'll be monitoring them. And if they're low risk with no recurrent symptoms, you'll just keep monitoring them and consider long-term treatment for them. And you might want to consider a PCI later on as an elective after, if you think they're more at risk of developing an MI. And then bypasses are usually reserved for people with multiple narrowed coronary arteries, which can't really be salvaged. And then in terms of long-term management, you'd want to ensure the patient's on an ACE inhibitor or an angiotensin receptor blocker. Put them on a beta blocker as well to control the heart rate. Put them on a statin, so the cholesterol is controlled so they don't keep forming these blockages. And you'd keep them on dual antiplatelets. Usually you would stop the clopidogrel or ticagrelor after a year of use. Some people, they might need it for other things like stroke risk as well, so they actually get kept on a bit longer. But in terms of MI, it's usually about a year. And then if they've just got angina, you'd consider some anti-angina drugs. So beta blockers or calcium channel blockers, put them on nitrates. With unstable angina, you'd treat them similar to an ACS and put them on all these drugs as well. Okay, and then complications of MI. Death is the ultimate complication. And then in terms of the timeline, within a few days, you're at risk of getting arrhythmias, cardiac tamponade, or rupture of the free wall, just because of all the ischemia that's going on there, your heart's not functioning as normally. Then heart failure can occur acutely, or you end up with chronic heart failure as well, and it's usually on the left side, and it can later develop into congestive heart failure as well, depending on which side of the heart the ischemia was on and how much damage there is. You can end up with valvular disease as well, again, depending on where exactly the ischemia was. And after a few weeks to months, you can develop things like aneurysm or Dressler syndrome, which is the inflammation of the pericardial sac. And just put this there as kind of a reminder of your anatomy as well, which is really useful to go over. And one thing to remember is that an MI can happen at any time. Okay, so the Gray scoring is something that you guys would need to know how to reference it to. So it estimates about 6 months mortality risk in patients who've had an end-STEMI or unstable angina. And there's another scoring system which they use immediately in hospital as well. This is kind of following their kind of discharge. You'd want to do this to see how likely they are of developing an MI or of death within 6 months post-discharge. So in terms of these numbers, I'm not actually quite sure how they get to these numbers, but on MedCalc, you can just put all these things in. So in terms of exams, it's just useful to know what goes in there and what the growth scoring is. And this just automatically calculates the probability and the risk score for you. So got another SBA here. So this is a chest X-ray of a 78-year-old male. He presents with shortness of breath, a productive cough, and a wheeze. There's widespread crackles heard on auscultation. So what's the most suitable diagnosis? So I'll give you a little bit longer for this one. So about 30 seconds. Just have a look at the chest X-ray and can just have a think about what it could be. Okay, so got B as the answer with a question mark. So B is the right answer. Well done. So I'm just going to go through clinical symptoms first and then go through the chest X-ray. But just on this one, you can see that, I don't know how much I can convince you, but you can see these curly B signs here. And this is usually because of the fluid in there, and it kind of makes the pleura of the lung, the lining of the lungs, a lot more prominent, which is why you actually get these lines in pleural effusion, pulmonary edema. And then you can see all these lung markings, and kind of they're a lot more prominent, especially around the hilar area. And this is your bat wing sign, and that kind of indicates there's a lot of fluid backing up into the lungs. You can see that bilaterally on both sides. Okay, so just in terms of clinical features, shortness of breath, frothy sputum are kind of classic signs, tachypnea, desaturating, and a raised JVP as well, but finding that kind of raised JVP is not always the easiest thing. They'll be pale, they'll be a bit wheezy as well, and they may complain of chest pain. And key things in their past medical history which can kind of point towards pulmonary edema, the first thing you would think about is heart failure. Sometimes you can get it in patients with COPD as well. It's not the first thing I would think of. Diabetes, valvular disease, and coronary heart disease as well. And you'd also want to review some of their medications if there's anything which might cause them to retain fluid. Okay, so in terms of investigation, you'd want to do blood, so renal function, so use an ease, get a glucose level, do a CHOP as well, because it could very likely be an MI, which has led to maybe acute heart failure, which has led to this. Check the liver functions, check clotting, FBCs as well, do an ABG on them, and a BMP is quite important as well to help identify if there's any heart failure. Do an ECG on them, chest X-ray, and an echo as well if they haven't had one within 6 months. There's not going to be that drastic a change unless you really suspect it within 6 months, so you don't really need to repeat the echo that often. And you'd also want to do a fluid balance assessment on them, so ideally catheterize the patient so you can monitor the output as well as the intake that the patient has for the fluids. So the way to differentiate between pleural effusion pulmonary edema is that with pleural effusion, you can see a clear fluid line within the pleural space. Like you can see here, like a little wedge. So this is in the mid zone. With pulmonary edema, you'll get the back winging, which I mentioned before. So it's kind of more prominent vessels, especially kind of winging out of the hilum on both sides. Your curly B sign, so it's a lot more prominent on this one than the previous chest X-ray that I showed you. You can see these little lines coming out from the side of the lung. And you'd also have an increased cardiothoracic ratio as well. So if it's more than 50% going across, then it might indicate a bit of cardiomegaly, which can point towards the cause of this pulmonary edema. So in terms of management, you'd want to put them on oxygen, make sure their SATs are between 92 to 98%. If nasal cannula is not enough, then you'd put them on a mask and then escalate them to a non-rebreathe. And then if that's still not good enough, then you'd consider something like CPAP or BiPAP. You'd want to offload this fluid, so you'd put them on IV furosemide. So typical dosing is usually 40 to 80 milligrams. And then with some patients, especially elderly patients, with furosemide, it works by binding to albumin, so you end up losing that. And without that, there to create the osmotic pressure, you'll start losing fluid as well, and you'll just have a lot more fluid, and that can lead you to be a bit more dehydrated. So what you'd want to do is actually change them to something, another drug called bumetanide, which is actually a lot more potent and a lot more friendly as well. And it works in the same way as furosemide, but it doesn't bind to albumin. You'd also want to ensure they're vasodilated to get the blood pressure down if it's over 100, because you don't want to put too much strain on the system. So things, GTN infusion is usually the common one. You do daily weights and repeat the chest X-ray to monitor the pulmonary edema and make sure it's all going down. And then you'd want to follow up and manage any heart failure that they have. Okay, so that was a nice little segue into heart failure itself. So this is kind of the struggle for the heart to actually pump blood around the body to meet our kind of oxygen demand. So you can get a high cardiac output, which is quite normal. It just increases your output to kind of to match the needs. So things like anemia, pregnancy, hypothyroidism, and AV malformations are common causes of this. With low cardiac output, this is where you start kind of seeing more symptoms. You have your right-sided heart failure, so things like edema, ascites, hepatomegaly, nausea, anorexia. And common causes are usually left ventricular failure, pulmonary stenosis, and any kind of lung disease leading to core pulmonary. And then your left-sided heart failure is divided into your heart failure with reduced or with preserved ejection fraction. So the preserved ejection fraction is anything above 50%, and this is something that you identify on an echo. And this is why it's really important to have at least one echo done within the 6-month period to kind of ensure their ejection fraction has been calculated. So things which affect can cause this is hypertension, restrictive cardiomyopathy, constrictive pericarditis, and pericardial tamponade. And then with reduced ejection fraction, that's usually below 40%. So this is your systolic failure. So it's struggling to kind of pump out. So this is your MI. So that's your ischemic heart disease, any kind of valvular disease as well. So you get this regurg and stenosis, which stops blood being pumped out. Hypertension can be a cause as well, and any dilated cardiomyopathy. Clinical features. very similar to your primary edema sometimes. It's shortness of breath, get a wheeze, fatigue. You can get peripheral edema, orthopnea, and paroxysmal nocturnal dyspnea as well. And the signs for this are raised JVP, a displaced apex beat as well. Just think about the cardiomegaly and your heart kind of moving, the apex of the heart moving away from where it would normally be. You would hear the crackles on auscultation. If they're a bit fluid overloaded especially, you'll get pitting edema. Ascites and hepatomegaly can also occur a bit later on. And if they're really congested, you can get added heart sounds as well, so an S3 and 4. So in terms of investigations, quite similar to the other one. You want to do their bedside observations. So check their pulse, check their blood pressure, heart rate and all that. Get your BNP, so if it's over 400, you'd consider heart failure. Under 100, it's usually a non-cardiac cause. I think if it's over 2000, it's an urgent referral for them to get an intervention. Check their electrolytes, so they can end up with hypovolemic hyponatremia. So it's just dilutional. Once they're uploaded, their sodium levels usually come back to normal. With any sort of thiazides or loop diuretics, they can also end up being hypokalemic. So you might want to think about changing the drugs. If it hasn't resolved the potassium levels, you might need to just put them on some potassium replacement. You'd also want to check their renal function, liver function, because anything going on with these can also lead to exacerbate your heart failure. And also check their FBCs and any hematinics to rule out any anemia that might be causing this. Do your standard ECG to rule out any cardiac other cardiac issues, chest X-ray, do the echo, which I've mentioned, and echo is not always definitive, so you might want to consider doing a cardiac MRI if you're suspecting anything a bit more serious, but that's not usually a common thing that's done. And this is just here because I thought this was quite useful from the NICE guidelines for your revision as well, just to kind of go through. This is just like a flow chart kind of putting together what I've just gone through. So this is just a classification system of the severity of heart failure, so the New York Heart Association classification. So your class 1 is usually the no symptoms, you're able to just carry on, your just normal functional status. Class 2 is when you start getting these mild symptoms, but you're comfortable at rest, but you might just have a little bit of shortness of breath on exertion and things like that. Class 3 is when you're not really able to do your normal activity. You might need to stop for a little bit. For example, if you're walking for a while, so let's say like climbing the stairs, and you'll be a bit puffy. And then class 4, this is where even at rest, you can get symptoms sometimes as well. Management is addressing any of the risk factors, give them diuretics acutely, and then consider any long-term diuretics as well to help kind of offload that fluid. ACE inhibitors and beta blockers as well if they've got left ventricular systolic dysfunction. And then you'd want to give them something like spironolactone and epilerone, which is a mineralocorticoid antagonist. And then specialist treatments that you'd kind of consider later on down the line, just kind of listed here, which is usually prescribed by specialists. And this is just kind of from the NICE guidelines, which I've summarised in the previous slide already. So you've got another SBA here. So you've got a 12-lead ECG that's taken from a patient in ED. So they fell due to syncope. What does the ECG show? So I'll give you about 30 seconds to just have a look at the ECG and put your option down in the chat. Okay, about 10 more seconds. Okay, so we've got C here. So yeah, that is the correct answer. So atrial fibrillation. So you can see, you can't really see any clear P waves. It's very irregular as well. So that kind of points towards atrial fibrillation. There's no indication of any STEMI or NSTEMIs here. No indication of any clear heart blocks either. And it's not your clear kind of sawtooth pattern to indicate atrial flutter. And with atrial flutter is a little bit more regular as well. In atrial fibrillation, your causes can be divided into cardiac and non-cardiac. So your cardiac causes are your hypertension, your ischemic heart disease, valvular disease, and cardiomyopathies. Non-cardiac causes include COPD, PE, pneumonia, pleural effusion, any kind of lung cancers, thyrotoxicosis, diabetes, infections, drugs and alcohol, and any other like electrolyte disturbances. And classic clinical features, you get palpitations, shortness of breath, chest pain, and you can have pre-syncope or syncope. So this is when you kind of start feeling a bit lightheaded, but you manage to kind of sit down, or if you're unfortunate, you'll just completely lose consciousness and fall. And then when you're checking them clinically, you'll feel that irregular pulse. There'll be kind of tachycardic, tachyarrhythmic, and you'd also sometimes these things are also found just by chance. So they might be asymptomatic, coming in from something else, and it'll just be an incidental finding as well. So AF can be divided into 3 different categories. So you've got your paroxysmal, which is kind of recurrent. You'll have more than one episode, which lasts more than 30 seconds, but it terminates spontaneously within 48 hours. And depending on your background and everything, it will determine if you need any intervention. Persistent would be anything that lasts over 7 days and requires medical intervention to terminate it. And permanent is something that you can't restore any kind of sinus rhythm, and this is where you'd start considering pacemakers. The investigations, very standard, OBS, ECG, bloods. You'd want to do things like magnesium, thyroid function, calcium and troponin as well, on top of all your standards. And then you do a chest X-ray, might consider a CT or MRI if you suspect any kind of embolic event. So with AF, it can throw off an emboli, which can lead to a stroke. So you want to make sure you rule that out. And you'd also want to do an echo, see if it's valvular. We've got another one here. So we've got a patient who presented with new onset AF within 48-hour onset. A2E assessment is completed and they are unrousable and hemodynamically unstable, which would be the next best step in their management. So we'll give you 30 seconds. I'll give you 20 seconds to have a think about this. Okay, so 5 more seconds. Okay, so saw that E was one of the options put down in the chat. So E is the correct answer, so you DC cardiovert, mainly because they're hemodynamically unstable, unrousable, so you'd want to just go straight for DC cardioversion. So this is the management of AF. So if you'd want to consider if they're hemodynamically stable or not. So if they are, then you do your ATE resuscitation and get senior input, and then your DC cardiovert. If they are stable, then you'd kind of get a good history from them, figure out if the onset was within 48 hours or if it's been more than 48 hours. If it's under 48 hours, then you'd give them rate control or rhythm control. If it's over 48 hours, you'd do that, and also you want to consider anticoagulating them as well. And then kind of 4 weeks later, do kind of a delayed rhythm control with any kind of cardioversion. That could be either chemical or electrical. And then long-term wise, regardless, you'd want to anticoagulate them after doing the transvascular for them and doing the HAZBLED as well, and weighing up the risks of them actually throwing off in their blood and leading to something like a stroke. Just to kind of quickly go through the rate control drugs as well. So beta blockers, usually things like bisoprolol, metoprolol. You can also consider things like diazelam or verapamil or digoxin as well in kind of sedentary patients with paroxysmal AF. And in terms of rhythm control, you've got your electrical DC cardioversion, or pharmacological, there's amiodarone or flecainide, which you can use. So amiodarone is usually in any kind of structural heart defects. And complications usually include things like stroke, which I've mentioned, sudden death, reduced kind of tolerance to exercise, and heart failure. So it's quite important to be able to remember your TRADVAS and HAZBLED. So your TRADVAS score, if it's over 1, you'd really want to consider anticoagulating them, unless they're female, asymptomatic, and they're quite young, then you wouldn't, because you already score 1 for being female. Then you'd also consider your HAZBLED score if they're at risk of bleeding after anticoagulating them, and you'd weigh up the risk using both of these if you want to give them an anticoagulation or not. Okay, so just going through some of the other kind of rhythm abnormalities. So I'm kind of focusing on the supraventricular tachycardias here. So you've got your AF here, which is your irregular non-sinus rhythm. Then you've got your atrial flutter here, which you get this kind of sawtooth pattern there. You've got your re-entry tachycardia, so your AV nodal one, and you've got one which goes through an accessory bundle. So these ones you kind of see here, your AV node re-entry ones where the current goes back into the AV node, and the AV node usually blocks off most of your the impulses and regulates that, so your heart range is usually between 60 to 100. Otherwise, it can go up to all the way like 300, because that's how many kind of signals it's being sent from the SAN. And you can also get focal areas which lead to atrial tachycardia as well. And I've just kind of put these different ECGs in there to help you identify, but they're not very common things that I've seen. In terms of atrial flutter, there's conduction patterns to also consider. So you've got this one here is a 3-1 conduction pattern. So you've got 3 kind of signals going through before you get that QRS complex. And this is different from the heart block, which I'm going to go through in a little bit. So with atrial flutter, again, you'd want to kind of consider if their hemodynamics is unstable or stable. Unstable, you go straight for electrocardioversion. With stable, you'd want to rate control them and try and get them to go back to sinus rhythm. And then you want to kind of consider kind of preventative treatments, so things like catheter ablation or kind of long-term antiarrhythmic drugs here, so like any kind of beta blockers or amiodarone are things to consider. Okay, got another SBA here. So what does the ECG show? Time me for about 30 seconds. About 10 seconds left. So got C, it's actually a type 1. So I will go over each of these. So type 1 Mobitz is usually where you have this kind of random drop off of your QRS complex, but otherwise it looks normal. Type 2 is where you can end up with multiple kind of, it's more like a pattern in there, and I'll show you a few examples of that. And complete heart block is usually the one where the QRS complex and the P waves don't correlate at all. So this is your first degree heart block here. So this is where you've got your P wave, your QRS complex, and the T wave, and the PR interval is usually quite prolonged. With your Mobitz type 1 here, you can see that it's actually quite regular. The PR interval starts increasing, and then suddenly it just drops off and then goes back. Type 2, you'll have this kind of pattern happening where you have normal, normal, and then drop, then normal, normal, drop. So that's a 2-1. Sometimes you'll have 3 normal beats and then a drop off. You can have 4 normal beats and a drop off. And then your third degree or your complete heart block is when you just have these P waves going through at their own rate, and you've got your QRS complexes going at a rate of about 40. So your AVN is able to kind of create its own kind of rhythm, which is roughly about 40 beats per minute. Okay. So this is just kind of going through your Mobitz type 2, the fixed ratio. So here you can see this kind of this is your atrial flutter bit here, where it's just kind of you have your 1, 2, 3, and then your QRS. Whereas in Mobitz type 2, you'll just see it kind of randomly dropping off after a couple of beats. So this is almost a 1-to-1. So clinical features of heart block is dizziness, syncope, feeling your heart kind of pauses, shortness of breath, nausea, and fatigue. With third degree heart block, it's just this intense tiredness. You have an irregular pulse, a really slow pulse, and you can go into cardiac arrest as well. Occasionally, you'll get cases where patient just kind of loses consciousness, but when they're lying flat, they'll regain consciousness, and that's because your horizontal and your blood's kind of able to go and perfuse your brain a bit more than when you're standing upright vertically. And with especially with like first degree heart blocks, it can also be asymptomatic, and it can just be an incidental finding sometimes. Management, if they're asymptomatic, you don't really want to intervene, you'll just monitor. And then you'd also review some of their medications and rationalise this, especially with things like beta blockers, calcium channel blockers, and digoxin. You might want to consider reducing the doses or actually stopping them altogether, because that will kind of affect if they've got a heart block, because they're already getting a bit more of a slower rhythm, they're not getting the signal through, and these things kind of lower the heart rate as well. And you may want to consider something like a permanent pacemaker as well to help pace their rhythm. So that's part 1 done. So does anyone have any questions?
Right, hi guys, I'm Ellie. I also studied at St George's, and I'm working as an F1 down in Exeter. Sorry, we've had a really mad day at work, and I've literally only just got in, which is why I'm a bit late to the start. But I'm here now and here to cover the rest of the cardio topics with you. So following on from what Ash has talked about already, so I'm going to start off my bit of the talk with an SBA. So this lady comes to her GP and she is complaining of legs that feel heavy and painful after prolonged periods of standing. She's got a history of type 2 diabetes and heart failure, and examining her, you see what you've got on the picture just there on the right. So some of those features there. So what is the most likely diagnosis for this lady from the picture you've got there?
So we got a D in the answer.
Okay, yeah, perfect. So it is D. So venous insufficiency is really common in older people, particularly elderly ladies, and it's a common cause of leg pain and skin changes. And BMJ describes it as functional changes in lower extremities due to persistent elevation of venous pressures. And that is explained really by the diagram on the right. So in a healthy vein, you've got the picture on the left, where the backflow of blood towards the heart, the valves are working nicely. You've got, as the blood travels up the vein, the valve should close behind it. However, you can see in the right-hand picture, because those valves are sort of incompetent and they let the blood leak back through, it leads to sort of trapping of blood at closed valves, and then you get this sort of bulging effect that we see in varicose veins. So elevated venous pressures might be due to reflux or valvular incompetence, and this might be primary, so it happens to a lot of elderly people with no obvious cause, or it can happen post DVT as well. Risk factors include increase in age, family history, smoking, previous DVT, or an occupation that's involved a lot of standing and walking. And it affects about 7% of the population, so relatively common. And findings on examination, so on the wards, you'll see a lot of older people with legs that look slightly like this. So you get the redness of the skin, and this is due to deposits of blood in the tissues, swelling of the ankles, and this can be confused with peripheral edema due to heart failure, for example. And these two things often do go hand in hand. But it's quite common for a lot of elderly people to say that their ankles are pretty much always a bit swollen, and that is more in keeping with venous disease rather than an acute event. You might see varicose veins, which we can't actually see any on these photos here. There may be some ulcers, so venous ulcers, to tell them apart from arterial ulcers, the venous ones are on the calf, and they're usually painless. And we'll talk about arterial ulcers in a little bit. You get the lipodermatosclerosis, which is thickening of the skin, and this particularly happens around the ankles, and also this whitening of patches of the skin as well. So how do we investigate? So the most important investigation is an ultrasound scan. So this can help us to visualize the veins and to look for any incompetence of the valves. If we've got really advanced disease, or we're thinking about doing some sort of intervention, we might want to do a CT or an MRI scan. That's not particularly common. And we can categorize them using this CEAP criteria. So thinking about the cause and whereabouts in the vein is affected and any reasons behind it. Some differentials for these sort of symptoms on the ward. So you get diabetic foot. That's often due to people not being able to feel where their feet are due to peripheral neuropathy. So they tend to be walking oddly or putting a lot of stress on a joint that causes damage over time. Arterial ulcers are distal and very painful, and they've often got this deep, punched out appearance. We've mentioned briefly leg swelling due to cardiac failure, and with this you'd probably expect to have some other symptoms as well, so things like shortness of breath on exertion, orthopnea, sort of needing to prop yourself up with pillows at night. And then you've also got lymphedema, so that's usually just one leg swollen, or sometimes you see it in upper limbs, particularly ladies who've had operations for breast cancer. They've had lymph nodes removed in the armpits. You can get this one swollen limb. And then in terms of management, for a lot of patients who are very elderly, they probably won't be suitable to have surgery, but we can help them with these pressure stockings, and they come in different strengths. It's really important to keep the skin moisturized, because actually if the skin starts to break down, then it's more at risk of ulceration and then infection later on. You can also treat varicose veins with invasive procedures, so you can laser them, you can surgically remove them, but unless this is causing the patient significant discomfort, the NHS won't do it, and it has to be a private procedure. All right, so then moving on now to peripheral arterial disease. So the most common cause for this is due to atherosclerosis. And as with all the other risks that atherosclerosis poses, things like heart disease, we want to try and prevent it before it develops. And 20% of over 80s, or over 20%, have a degree of peripheral arterial disease. But most people don't have any symptoms until they've got severe disease. So the features that we're looking for are things like intermittent claudication, so cramping pain, particularly in the buttocks and the thighs, and this stops when they have a rest. So one thing that you might get in the GP practice, for example, is a patient who comes in and they say, "Oh, doctor, I can't walk as far as I used to," and then you have to clarify, what's stopping them from walking. Is it that they're getting short of breath? Are they feeling dizzy? Have they got pain? And that can help you narrow down some differentials. I've briefly mentioned Berger's disease. So this is a rarer type of peripheral arterial disease that affects young, usually male smokers. And this is inflammation of the veins and arteries that's not related to atherosclerosis. So here we've got some feet with some arterial signs. So you can see on the right hand side the tense, shiny skin. There's no leg hair, also there wouldn't be hair on those feet anyway, but further up on the leg you start to lose the hair growth. You can see the toenails are thickened. If you feel for the pulses, they may be weak or even absent. And here on the right hand side you can see there an arterial ulcer. So it's very distal, it's near the end of the foot, and that's quite painful as well. And then in terms of investigations, so we want to exclude other things, like particularly diabetes, which is very common. And then the most important test is actually done at the bedside, and it's this, what we call the ABPI. So you literally apply the blood pressure cuff to the calf and you pump it up, and then take it's often the vascular nurse specialist that will do this test. So they look for a certain value, and just if you remember those values, so normal is 1 to 1.2, peripheral arterial disease is 0.5 to 0.9, and then below 0.5 we call critical limb ischemia. So there's a high risk that the blood flow is going to be disrupted altogether in that state. You'd also do an ultrasound scan, and if we're thinking about putting in any stents or doing anything, we'd also want to do some CT or MRI. And then we've also got this, what we call Fontaine criteria. So it's basically staging how bad the disease is from asymptomatic all the way up to ulceration and gangrene, which is a feature of critical limb ischemia. Okay, and then in terms of management, so we've already mentioned that it's important to prevent rather than cure if we can. So optimize other conditions, things like high blood pressure and high cholesterol. And we can also prescribe an antiplatelet if they're not at risk of bleeding, and clopidogrel is first line for that. Exercise is actually encouraged for these patients. So a lot of the time they won't want to exercise because it's painful, but actually it's shown, there's evidence to show that if they just do a small amount of exercise, it can improve the blood flow to their lower legs. However, if that's not enough, then we've got some medical options, so some vasoactive drugs. We tend to go for surgical options over that, that vasoactive drug because it's got a much better effect. But if the patient is not fit for surgery, or they just don't want to have surgery, then they can have that option. Or otherwise, there's various sorts of surgery that we can do. So we can use a balloon stenting device. We can do a bypass using usually the great saphenous vein as a skipping the gap that's been blocked off by the atherosclerosis. Or we can, in some cases, amputate the leg, particularly if the person's in terrible pain, and definitely if they've got an infection or gangrene. Okay, so next SBA. So this man comes to A&E. He's had on and off leg pain for several months, but today the pain is really bad and he got sent home from work. He's got a bit of a medical history with angina, diabetes, and has had gallstones. He's got high BMI. He's a current smoker and a drinker. And on examination, you see his feet here. What do you think we should do for this man?
So got D.
D, yeah, fantastic. Yeah, D is correct. So this is acute limb ischemia. So the next step after critical limb ischemia is basically complete occlusion of the vessel. And this is an emergency. And really, if the limb is not, the blood flow is not restored within 4 to 6 hours, there's a high chance that we're going to have to remove that limb. So it may be due to an acute thrombotic event on the background of atherosclerosis, or if they've already had a stent put in, these can occlude. It can also be due to a trauma, and it often presents like this. The patient has got a history of peripheral arterial disease, and then all of a sudden they become a lot worse. And you've got the 6 Ps of acute ischemia. So these are really good to remember for your exams. Pale, pulseless, painful, paralysed, paresthesia, which is tingling or numbness, and perishingly cold to touch as well. So investigations and management, we want an urgent CT angiography. And sometimes we do, if we really suspect that someone is in a high thrombotic state, so they're very likely to have clots, we can do a CT angiogram all the way up to the aorta. We actually had a patient on the ward that had that recently because he was very vasculopathic. But once we've got the scan, we can see the extent of the occlusion. And then we use this table here, it's called the Rutherford score. So if the limb is either viable or it's just slightly threatened, we can give them heparin. If it's immediately threatened, then it's a surgical option is best. So an embolectomy, go in with a Fogarty catheter, which is basically a little grabber, which goes in and grabs the clot and removes it. But if it's irreversible damage, Rutherford 3, then amputation is the only option. And then after we've treated the person, we want to give them an antiplatelet or even anticoagulation, because they are more at risk of having a recurrence. If we've removed a clot, obviously we've reperfused the leg. However, there's a risk of getting this reperfusion injury or compartment syndrome. So I won't go into those too much here, but compartment syndrome is a interesting one to remember for exams, because it's the sign is pain that is out of proportion to what you're seeing on examination. So if a person's had recent surgery on their leg, for example, and they say, oh, I've got this awful pain, 10 out of 10, and you examine their leg, and perhaps the thing you would feel is a bit of tension of the skin if they would let you get that close to examine them, because they're often, but actually it doesn't look that bad. But can be a warning sign for that sort of condition. Okay, so next we've got this man. So he's 25. He comes to A&E because he's very tired and he's got new severe shortness of breath. The last 2 weeks he's not been feeling too well either. He's sort of lost his appetite. He's got lots of muscle pain, and he's not working at the moment. He's still smoking 10 cigarettes a day, and he drinks most nights of the week. His dad died when he was in his 40s of an unknown heart condition. And then here on the right, you see these signs when you examine him. So what is the most likely diagnosis, do you think?
Ellie, I think your audio is a little bit muffled all of a sudden.
Okay, that's fine. I haven't moved my computer. Is that better?
Yeah, that's a lot better. Yeah.
Lovely. Okay.
Oh. And got C.
C, yeah, fantastic. I'm very on it this evening. So yeah, so C is the right answer. And those signs here, so here we've got on the bottom splinter hemorrhages, we've got Janeway lesions and Osler's nodes, and then here on the top, so these are actually what we call track marks, so signs of injecting IV drugs. And the reason I put that there was just you don't often see many pictures of it, but it's a big risk factor for getting endocarditis. So infective endocarditis is an infection of the valves, and it's most commonly caused by Staph aureus, can be subacute and caused by other pathogens as well. And the key feature is fever plus a new heart murmur, and this is infective endocarditis unless we prove otherwise. So if they've got that, we need to do imaging, so an echocardiogram to look at the valves. There's a high suspicion if there's 1 week of a fever that we can't explain in people that are high risk. So people that have got indwelling lines like PICC lines, people that use IV drugs, or people that are vulnerable, so immune suppressed or diabetic. There's also this thing about recent dental surgery, which you'll definitely read about in some of your textbooks. I'll come back to that in a moment, because they have had a rethink about how much of a risk that actually is now. And also if someone's got an abnormal heart valve, so a bicuspid instead of a tricuspid valve, for example, they're also more at risk. Features of infective endocarditis include symptoms of sepsis, which are very generalised. Skin, we've got some specific signs, Janeway lesions, Osler's nodes and splinter hemorrhages. And there's also cardiac symptoms, so a heart murmur, signs of heart failure such as oedema, orthopnea and shortness of breath. So here's just some pictures of the lesions that you might see. And then also you can get Roth spots. So if you do a fundoscopy, you can see these spots on the retina there, and they are sort of tiny little hemorrhages that have happened. So that's another sign that you might see in exams as well. Okay, so investigations. The key investigation to do is an echo. So you can see here on the right, and that helps us to visualize the heart and see, you can literally see what we call vegetations, which are these little bacterial growths on the valves. We usually do echocardiograms on the chest wall, so a transthoracic echo. However, the best test for infective endocarditis is a transesophageal echo. So we do an endoscopy basically, and the ultrasound is passed through the wall of the esophagus, and you get a much better view of the heart. But often, if patients are very sick, that might not be suitable because it's quite invasive, or some patients may refuse to have that done, in which case we just go for the transthoracic. It's also important to do some blood cultures. So they say to do 3 separate blood cultures done at different times from different sites. And I think you have to get something positive in all of those to confirm that it definitely is infective endocarditis, but don't quote me on that. I think that's the case. So other blood tests, they may have an anemia. They've usually got a raised white cell and a high CRP. They may also have a positive rheumatoid factor as well. Some diagnostic features. So you don't need to remember these for your exams, so I didn't list all of them, but it's what we call the modified Duke criteria. So there's major and minor criteria, and the big major one is the positive cultures and a positive echo. Minor features are risk factors, persistent fever, and they're minor because I guess they could be related to other conditions rather than this, whereas the major factors are pretty diagnostic for this condition specifically. And then management, so they will need intensive antibiotic therapy for over a month. And this is IV and it's done in hospital. If they've got a valve replacement, you need even stronger antibiotics. Obviously, with things like gentamicin and rifampicin, you need to watch out for people's liver function, their kidney function, and their hearing. And with surgery, so if the valve is really damaged or they've gone into heart failure, then we'll need to replace or repair the valve. And then back to this sort of historic feature that dental procedures are a risk. They are, that is true, but however, they've now reconsidered that and they feel that only high risk individuals having dental procedures actually need to be covered with antibiotics. So very high risk individuals include people with prosthetic heart valve, people with congenital heart disease, and if they've had infective endocarditis in the past. So those people will get cover with flucloxacillin if they're having an invasive dental procedure. Okay, doctor, come quickly. The patient in bed 3 is unresponsive. So you go to see the patient in bed 3, and here you've got Mr. Aziz. So he's a 78-year-old man, and he was doing well on the ward, recovering from a STEMI. But he's now slumped forward in his chair and he's not responsive. So what's the most appropriate next step in this situation?
So got A as an option.
Okay, yeah, brilliant. So A, definitely. So the hospital is the best place to be for this. If you call 2222, you'll get a whole team of people coming running. And then obviously all of the other options I felt were reasonable. Once you've done the 2222, then you can start with B. So if you're the first person there and you recognise they're in cardiac arrest, then you can start the CPR, but at least you know you've got people coming to help you quite shortly. So cardiac arrest is a sudden circulatory failure due to loss of cardiac systolic function. It's got quite a low survival rate. One of the things that always annoys me is when you see on soap operas and things on television, people having CPR and then waking up and coming round. And I think because of this, a lot of patients that come into hospital have an unrealistic idea of how successful CPR will be. And it's often why people are quite reluctant to sign DNA CPRs, because they feel that, you know, this is likely to be successful. In reality, it's got a low survival rate, and if people do survive, they often require a lot of support, often on ITU. So we really have to think about the patient before we say that they're suitable for CPR. And you've got 4 specific rhythm disturbances in cardiac arrest. So VF and pulseless VT, which are both shockable with a defibrillator. And then you've got PEA and asystole, which are not shockable. So we'll go on to how we manage those in a moment. So the crash team arrives and you're all doing the CPR. And when you put the chest pads on, you get this pattern on the AED. So which rhythm do you think that is?
So I got E here.
E, okay. E.
I think
Unfortunately, it's not E.
Or D.
Or D. Okay, no place. So this is actually VF. So here we've got all of the arrhythmias laid out. So VF is like, I always think it's like a child scribbling all over the ECG paper. It's really disordered, lots of little sharp points, and that is just the ventricles sort of flapping around and, you know, not really doing anything to pump the blood round. VT, on the other hand, you can see here on the right, that looks slightly more organised. It still looks very chaotic, but it's like these very specific large peaks going on. And then torsades de points, or points, as somebody once said to me, this is technically a form of VT, which is why I didn't put it into the 4 rhythms. But with this one, you can see, if you look at the very points of the QRS complexes, they're kind of twisting upwards. And that is can be related to low magnesium. You can get torsades de points, but it's quite rare. It's often just regular old VT. And then PEA, you see down here, just looks like a pulse. But the patient is, when you feel, they haven't got a pulse and they are completely unresponsive. And, you know, the defibrillator in that case will advise you to continue CPR. And then asystole is just a flat line. So back to the scenario. So you give a shock and normal rhythm's not restored. And then you carry on with CPR and you give a second shock. What could you give at this point that might help to regain circulation?
So I've got B here.
Yeah, definitely. So B, adrenaline. Perfect. So I'll come on to that in a second. Yeah, so adrenaline definitely. And we can, for the non-shockable rhythms, so the PEA or the asystole, giving the adrenaline can help to kickstart the rhythm again, along with the CPR. For the VFs and the VTs, it's the shock itself that is often successful, although we can also give a adrenaline after a couple of cycles of shocks if it's not working. For the PEA and the asystole, we'd look to give adrenaline as soon as possible. Okay, so after the second shock, you do several more cycles of CPR, and he does regain spontaneous circulation. He's transferred to ITU for ongoing monitoring. One of your HCAs is particularly upset, and she tells you afterwards that recently she was out at the local pool and she saw a child pulled out of the water who was unresponsive. The child did recover, but she's obviously very upset by what she saw. So in this scenario, how would, if you were going to do CPR on a child, how would resus differ compared to Mr. Aziz?
So we got B as an answer?
Yeah, B is correct. It's a slight trick question because there is also another answer you could say for this one.
So A?
Yeah, perfect. So A and B are correct. We can use defibrillators on children. We often have, in hospitals, you can have paediatric pads, and often in the AEDs you find out in public as well, there are paediatric pads very often, or with the adult pads, if it's a larger child, sort of, you know, maybe not a baby, but a larger child, you can use the adult pads and put one on the front and one on the back if you're in public. You can give adrenaline to children, and then using thumbs, that's CPR for newborns and very young babies. So a summary of CPR. So Dr. ABCDE still applies in hospital. You know, your danger, hopefully there won't be much danger in the hospital ward, but, you know, just to check what sort of drugs they've got running or if there's any sharps lying about. And then calling for help as well is your 2222, and then following your ABCDE. So you'll find if you go to a cardiac arrest, there's often someone that arrives, starts to run the arrest, like a registrar or a consultant, and they will go through the ABCDE because they're trying to pick up, is there any reversible cause that we can find that, you know, has caused this arrest that we can change. For adults, it's always the 2 initial rescue breaths and then compressions at 30 to 2. And there's often a COVID protocol in hospitals now where you have to gown if they're not definitively COVID negative. In children, we give 5 initial rescue breaths and we do 15 to 2 compressions. The 5 breaths is because often children will collapse because of a respiratory cause rather than a cardiac one. And for very tiny children, tiny babies, we use 2 thumbs to do the compressions. If they're a young child, so, you know, perhaps would say under 5 or 6, we can use 1 hand, and then older than that, we just use the same as we do for adults. And an AED is always a brilliant idea if you're out and about and you get into a CPR situation, and there's a lot of them around these days, so it's great to have one of those. Okay, that's the end of my section. Does anybody have any questions?
So